because on Earth we have a complete setup, but on board, there are only on board, we only have three pieces of equipment upon which they have to exercise. So this one, the equipment, we call it as ARED, that is Advanced Resistive Exercise Device. Now, this is slightly different than the squat rack in the local gym, but it has similar functions that we can do the squats, deadlift, bench press, shoulder press, and the other exercises. The principle on which it works is that it has two canisters and that have vacuum in them. So the astronauts, they pull against the vacuum to exercise. The goals of pre-flight training are to prepare the astronauts for space, obviously, to conduct pre-flight measures, to familiarize them with the in-flight training program and equipment with the correct techniques, and to treat any pre-existing conditions if they have it at all. Now, keeping in mind all these things, we train them, but like I said, there are differences between which particular space agency the astronaut will be flying to space. So you would see that there are differences among the type of equipment they use because it depends whether the astronaut will have access to the NASA module of the International Space Station or the Russian module. Yep. All right. So once this pre-flight training is completed, then comes the in-flight stage where they are flown to space. Now, in-flight exercises, the goals are to maintain good health conditions and high work capacity of crew members, to mitigate the effects of microgravity on different systems, to save the coordination abilities and allowing them to maintain the vertical position or to walk or run in case of emergency after return to earth. Although there is the crew members would be there to receive the astronauts, but in case of emergency this is very, very important. Now, the in-flight exercise countermeasures, they are divided into three phases. Phase one is the adaptation phase, which usually lasts from 1 to 20 days of their arrival to space. And there are individual differences how fast an astronaut can adapt to microgravity. And this phase, we also give time to the astronaut to familiarize themselves with the hardware and adapt them to exercise in the actual microgravity environment. Phase two is the main phase. This is to prevent the microgravity effects and the exercise with full fledged. Phase three is preparation of re-entry. That's the final 15 to 30 days if it is a long duration space mission. And here the emphasis is to prepare the crew member for rigorous re-entry and potential off-nominal landing scenarios. So on board, in the NASA module, you have three pieces of equipment. The first one is the Seaverse. I'm not sure why they. Can you hear the sound? Okay, so this one is Seaverse, that is the exercise bike. Its full form is cycle ergometer vibration isolation and stabilization. So it is the usual exercise bike what we use in the gym. And the CVS protocols, they are based on pre-flight maximal oxygen consumption, that's the VO2 max. Um, for example, if the astronaut is from the Canadian Space Agency, so they use the steady state protocols that are performed approximately 80% of the pre-flight VO2 max. All right. Now, the second one is the Colbert, that is the combined operational load bearing external resistance treadmill. This treadmill is used in both motorized and non-motorized modes, and it provides motorized speed up to 20.4 kilometers per hour. Again, same, the treadmill protocol's intensity will be increased throughout the mission by modifying either the running speed or the interval duration. And the last equipment here is the ARED, which we have just seen in the pre-flight stage. The advantage of ARED is that it provides load from 2.2 to 272 kilograms. The resistance exercise program, it is composed of two phases. The first phase is to allow the crew member to adjust to the microgravity environment and to determine the appropriate loads for resistance training. And phase two would be focusing on mitigating the effects of microgravity. Now, as the bones and the muscles of the lower limbs, they are more sensitive to microgravity adaptation. So the main resistive exercises which are prescribed are squats, heel raises, and deadlifts. And they are performed during every session with minor variations, like maybe there can be a sumo squat somewhere. Now, to having said that, that we emphasize mainly on the lower body, but to ensure a comprehensive whole body workout, a range of other resistive exercises like bench press, they are included, and they varied from session to session. Once they are back on Earth, this is where the post-flight session or the post-flight phase starts. So, like in flight, the post flight is also divided into three phases. Phase one is back to gravity, usually 1 to 2 days. Phase two, back to function. So, third day to approximately 10 days, because there are evidences which says that within 7 to 10 days to most of the body it adapts to gravity again, and after 10 days we is the back to work. So the goals here is to prevent short-term and long-term painful conditions from developing, like low back pain, and addressing any mission induced physical health problems. Then it would be returning to the astronauts to their pre-flight condition without risking the development of pain or injuries which are associated with readaptation or which are associated with resumption of loading. And the final goal would be to prevent any long term effects of space flight on their body. Usually, we have very limited data on how microgravity affects the body, during long term phase. Now, so the program, the post flight program, it advances through 45 days, and specific attention is given to each astronaut's overall conditioning, the testing results, the medical status, the assigned duties after their missions, and so on. For this, different test batteries have been developed. So, first, they are being assessed using a particular test battery, depending upon, again, which space agency it belongs to. Functional task test is just an example of interdisciplinary testing regimen which has been developed to evaluate astronauts' post-flight functional performance. Sorry?
नेहमी म्हणत होते किती ते किती असणार आहे यांचं
Can I proceed? Hello?
Yes, ma'am, please do.
All right, yeah, thank you. Yeah, so for example, I was talking about the functional task test. This is again a testing battery which has been developed to evaluate astronaut post flight functional performance and related physiological changes. So once this assessment is done, then comes the reconditioning program. I've tried to jot it down, exercises and how they are being incorporated during this 45 days of reconditioning program. So 45 days is the standardized NASA's reconditioning program, but it could go more than 45 days if the astronaut needs more attention or more sessions from our side. So there would be daily 2 hour session. The first hour is dedicated to physiotherapy, addressing any specific conditions if they are suffering from. The first week, the exercises are performed in swimming pool in coordination with the gym sessions. So the feeling of neutral buoyancy in the water is perceived as comfortable by astronauts, reminding them of the absence of body weight in microgravity. Now, as the crew member progresses, the gym time versus pool time, it is increased, and physiotherapy exercises are also performed in gym. Now, in the main phase of reconditioning, more time is spent in the gym performing the resistance exercises rather than in the pool, and also maybe in the specialized room. Initially, the program focuses on basic ambulation, the cardiovascular endurance, strength, balance, flexibility, and proprioception. The second phase will concentrate on more active conditioning regimens by adding higher intensity aerobic exercises, strength training, as well as induction of power type exercises like jumping or medicine ball exercises. Concurrently, more complex movements for balance, agility, coordination training, they are progressively added according to the astronaut's tolerance. So that means that in general, if you want to just remember about the reconditioning program, so between R1, that is their day of arrival, to 21 days, the intensity level it is increased progressively without evoking any strong physical effects. However, after 21 days, up to 45 days, the individual training program for a particular astronaut would be similar to what they have been practicing during their pre-flight stage. The post-flight stage or the reconditioning program, it continues until the crew member has regained pre-flight fitness level, because that is one of the very important goal. And in the third phase, then they are released from formal post-flight reconditioning program once we feel they are at the baseline, but they are encouraged to participate in a maintenance program. So having said that, overall, if I have to say it, and I know the media has created a lot of buzz about astronauts' health, which is again a good thing, I would say. It is completely agreeable that microgravity leads to deterioration of all bodily functions, but we have to consider this that the body is adapting to a new environment, and it is only unfavorable adaptation because the astronauts are going to come back to Earth's gravity. And second thing, because of the pre-flight, in-flight, and post-flight program, we are in a very good position to, to bring them back to their baselines. So just to conclude this my session very quickly, I would just like to play this video, which is one of my favorite video. I always say that I am a physio, so I am an advocate of exercise, whether it is on Earth or in space. But let's hear what this astronaut has to say. Yeah. So even they agree, and even evidences support that the best way to stay healthy in microgravity environment is through exercises. Right. Thank you so much for your time, and I'm really sorry for the technical glitch. It's been an honor to provide you an overview about this important topic. Just like as we look to the future of space exploration, and India is also coming up with the human spaceflight program, I encourage you all to stay engaged with the latest research and advancement in this field. And I'm sure it's not only Sunita Williams, but the next is Subhranshu, who will be flying to space. Thank you so much once again. Yeah, and I hand it over to you, sir.
Thank you so much for joining us and delivering an engaging and informative guest lecture. Ma'am, your insights and expertise brought real world depth to our session, and your presentation sparked meaningful discussions that our group truly appreciates. Thank you, ma'am.
Thank you so much. It just, sir, are there any questions or I'm okay to leave the meeting?
Good afternoon, ma'am. Nice to hear you.
I'm so sorry, ma'am.
It
Your voice
was
is
an
breaking.
excellent topic and excellent presentation with the videos. I just wish to.
Ma'am, I can't hear you properly.
Can you hear me now?
A little better, but your voice is still breaking.
Ma'am, can you hear me?
Yeah, it's much better now.
Okay. Just wanted to, just wanted to know that how much, at least mean duration required to recover from this just changes.
So, ma'am,
Means
it's
how many days it requires to recover when the
yeah,
person is in space or in
yeah.
the plane, right? So how much duration is required to recover
So
on an
when the
average?
so
Yeah.
when the astronaut comes to Earth back, yeah,
Yes.
yeah. So it is said that around 7 to 10 days is needed for the systems to readapt to gravity, and that's why we keep the exercises very minimal till that day, because and after that, because the systems they start to responding, which they haven't been doing in the space. After
Right.
that, it's a good time for you to integrate the exercises and increasing the complexities.
Okay.
But like I said, NASA has found it out that this 45 days of duration is, more or less similar for most of the astronauts to bring back to their baseline, that is the pre-flight level, which is very important because this would not be the only mission they would be flying. There is possibility that the astronauts again has to go for another missions, or they may have another assigned duties here on Earth.
Yeah, that's true. Thank you so much.
Thank you.
Yeah.
Are there any more questions, or
Ma'am, may
can I leave?
Yes, could I just ask one question?
Yes, please.
Yes, ma'am. Excellent session, first of all, I would like to say.
Thank you.
Second thing is we have a lot of students who are here,
Mhm.
who have joined the session physically as well as online. What are the ways in which we can take up, the career that you have pursued after physiotherapy? How is that our students can go forward with this? So if they have to go in for astroscience or astrophysiotherapy, so how is that? If you can just guide in short to our
Yes.
students.
So to be very honest, I have taken a very, very unconventional path. When I started, there was very minimal resources about the role of physiotherapy, and if you're talking about Indian students, unfortunately, none of the universities who are delivering the physiotherapy program are teaching this. But if the students are interested, I would first say they'll have to get some knowledge about it. It could be either by doing some research when they are doing their undergraduate projects or their master level thesis. There are been grants which are provided by DST India. There are institutions abroad which offers MSc programs or master levels and doctoral programs. Some of them are funded, so they can look for it, if they want to go ahead with it. Another way, because now India has started also the analog astronaut program. It was, I don't remember the organization, but it was from ISRO. They have, collaborated with ISRO, and last December or somewhere in the last quarter of 2024, they have started with analog astronaut program. So the universities can collaborate with them and do very small projects, because directly getting a job, so if the students are wanting to become a physio in a space industry, very high level of um, qualifications are needed. The opportunities are very rare if it comes up. Like as of now, what I know is ISRO has only one physio who is training 4 astronauts. Okay. And because we do not have the experience in India, and Subhranshu, he is due to fly Axiom 4 space mission. So he's been trained in NASA and ESA. So that's what I'm saying. It's very difficult for me when it's say, but the first step would be, having more knowledge. And the other way, apart from research, or it could be like attending these space conferences, which are specifically focused on astronaut health, because there you will find, speakers coming from various backgrounds and delivering very good lectures, and you'll find resources there as well. Astrosize, which I launched, is also, is also providing this opportunity to students. So we are developing our website and putting all the informations. We have our own community. Astrosize has its own community. If students would like to join that, please let me know and I can forward the details. So what I do there is I share, whatever future opportunities are there or any new relevant research is there. We have few programs from Astrosize, like we have launched 45 days of campaign where you can just ask any question and tag us if you have any query and we can answer it. So you have to look into it. But what I would say is the starting point would be having more knowledge about this field. Other than that, you cannot progress forward. But if you want to have the easiest way, it is to enroll in a research program at MSc level or doctoral level, and from there you can develop more opportunities. Thank you.
Ma'am, may I?
Yes, please.
Thank
Ma'am,
you,
I
ma'am.
have
And we are
multiple.
extremely proud of having you with us, and definitely privileged if you would be able to collaborate in future. Thank you. Thank you so much.
Yeah, sure. I would be very, very honored, to be very honest. And that's why I have founded Astrosize, because I know what I have gone through. No resources, no mentor, no direction. Even when I wrote to ISRO back in 2015, I got a reply that they are not planning any human space flight. So I started doing this, approaching, because I was in India at that time in 2015, and I got that negative reply, but I did not stop. So what I tried is, how much, what I could do. But when I say that you pursue further studies in abroad, let me make it very clear, they are very expensive. So please make sure that you have funded programs, and you actually can get those fundings or scholarships. Thank you.
May I?
Are there, are there further questions, sir? Because I am running out of time. I can take one last question. That's it.
Ma'am, may I?
Yes, please.
Ma'am, you just in your slideshow mentioned that the pre-flight training is almost 2.5 years long, where the astronauts spend thousands of hours in the gym and adapting to the equipment on board, and microgravity sessions are given to them. But the post-flight rehabilitation is only for 45-50 days. So, in your personal opinion, would that be enough to compensate for the few hundred days those astronauts are in orbit, or does it take approximately 45 days to just go back to functioning, and then the extensive rehabilitation is followed for 1.5 year? And what does that include? Because all the systems are involved other than the neuromuscular system.
Excellent question. So I would say all the systems are involved. Because of the time constraint, I couldn't explain the physiology and, cover other systems like your bladder or, or maybe the reproductive system and so on. So when I say that the mission is assigned 1 to 2 years prior, that doesn't mean that they are only exercising. So exercises are a part of their schedule. Okay, they have to undergo very, very small training. It's just like, training a newborn. So, how to maintain hygiene, how to conduct the experiments, how to walk, move around in the International Space Station. So, there is lots. And, even survival training. So, they will be deployed to an isolated area, say for a week or even for more than a month. So to undergo the survival training, they go underwater training. They have to also do, familiarize themselves with the tools, equipment. So physiotherapy is just a part. When I said, 1 to 2 years prior, it's actually when the mission has been assigned to them. And then what is the mission assigned to them? Because, for example, if the astronaut will be doing an EVA, that's the spacewalk, then the exercises is going to be different from those astronauts who are not going to do an EVA. Okay, so and the hundreds of hours is the calculated one along, around 1 or 2 years. And it's usually if they are the first time flyers, there can be somebody who is just, within 6 months, they have been picked up for a space mission and they fly. So this is the duration where they are being trained for each and everything. Trust me, because they have to learn or every single step what we teach to a baby, because they are going in a new environment, and they will only have those 5 or 7 people around them. So from ground station or from the mission control, we can only provide them a command. All right. Having said about that, and having said about the system's deterioration, I would like to emphasize that it is deterioration or decline because they are going to come back to Earth. If we see they are going to stay forever in space, that is the natural adaptation which is needed for them to function normally in a new environment. So it is only deconditioning, declining, or whatever you would like to say. It's just because they're going to come back to gravity. Okay, and this 45 days, if I did mention that first 2 weeks or first to 20 days, we give time for the astronauts to adapt to the microgravity environment. So our body is so beautifully designed, that it as soon as you put it into a new situation, it automatically starts to adjust to it. So that's what happens. So if there are something called as immediate response when you change the environment, it could be microgravity or back to 1G environment of Earth. But the time duration, what has been found out is that the systems to restart working, it usually takes, 7 to 10 days. I completely understand, the confusion why my presentation may have created is because I couldn't go into depth why this is happening. I could only point out what is happening to these systems. So when in physiology is what are the changes and why are the changes and how are the changes happening, it becomes more clearer to us. Yeah. So this 45 days is enough because it is not a pathological changes what we have seen in the astronauts, but it's the normal physiological changes what we have seen due to change in the environment. I hope that answers your question. Thank you.
Thank
Can
you,
I
ma'am.
have one? Yeah. Can I have one question, ma'am? I'm Dina.
Is it okay if you can just type and he can forward because I'm getting late for my appointments here.
Okay. That's okay. I will send the question straight to the
Yeah,
question.
yeah, of course. Please I mean, to the organizing team, if anybody has any questions, just if you can email me and I will definitely answer
Okay, okay.
them.
I'll do it. I'll do
Yeah,
it. Thank you,
I'm so
ma'am.
sorry about that.
Okay, okay. Thank
All
you.
right. Thank you so much for having me there. It's truly my honor to be here. Thank you so much. And I hope you all have a lovely day.
Thank you, ma'am.
Thank you, sir. And I'm sorry, I'm really getting late for my appointments now.
Yes, ma'am.
Yeah. Thank you. Bye, sir.
We'll be starting with the second guest lecture.
हे तू माझं फोटो काढू नाही शकत तू.
Atau FMBP ya. So everybody. And technical issues are there. Yes. So under the functional evaluation, you're supposed to cover the same things that which I told you earlier, different types of grasp. You have to check the ability of the person to move, the quality of the movement, the strength of the grasp and everything, and then the stage of recovery. We know that there's something called as Brimstone stage of recovery, as well as those scales or outcome measures that are evolved based on the Brimstone stage. The main important one is human hair scale and all those. If you can see here, these are the stages of recovery when it comes to hand function. And equivalent one is therefore the upper extremity devoid or without the hand into account. And then you can see the traditional methods are there using dynamometers as well as pinch meters and all those things to check the strength of the muscles. And comes to the outcome measures. Now, I'm not going into all the aspects of outcome measures. Only the important one will be covered. Only the salient features will be covered. Because there are any number of outcome measures there. Some of them are quite popular. Some of them are considered to be gold standards or near gold standards. I'm using that word. Actually, there's nothing called that. But what I'm trying to say that they are commonly used. Human hair is one of those. Wolf water or WMFT is there. Action reaction research arm test is there. Then those are basically, to check the motor functions. And then box and box test is there. Similarly, 9-hole test is there. That is basically for checking the dexterity specifically. And then there are many other tests too, but I'm here highlighting one more new test, what is known as Buffet, which we have developed in KMC Mangalore. We have conceptualized that particular method. Recently, it got published in a Q1 journal and Taylor and Francis, and it is already Next slide. So it's basically an employment-based assessment tool, basically evaluating the upper extremity and also the rest. Say, for example, upper extremity score is around 66, the lower extremity is around 34, you get around 100 score is there for that particular thing. Similarly, there are some other subcomponents when it comes to fecal wear. But when you are specifically talking about upper extremity, FMA alone can be advocated. We can use that also for research purpose. And primarily this was developed by Mitchell and Brunstrom. Again, just to talk about the history, if you guys know when the two people that which introduced this scale, either there were a lot of debates also. Finally, some of the people said that like it should be mentioned as Brunstrom's fetal wear scale because it's literally nothing but the components of Brunstrom's assessment. But then, technically speaking, Brunstrom is no more. So there's nothing called as copyright violation issues and all those things. Again, people are continuing to use the word fecal wear scale, but originally it has been called as Brunstrom's fecal wear scale because literally entire components of Brunstrom assessment scale is being used. Coming to the next one, the subcomponents, there are many, as I already told you, the maximum score for FMA upper extremity is 66, and it's an ordinal scale, it's a 3-point ordinal scale. Going to the next one, another important scale that we use very commonly in our field for research as well as for evaluation as an outcome measure to see the efficacy of the treatment, changes or whatever it is. Like that is next one is a Bush motor scale. It's a quantitative measure for basically evaluating the functional abilities of the upper extremity. And there are also components where the measurements are time-based also. Total 21 items are there, of which 15 around items are functional-based one, and 2 of them are specifically checking the strength. Initially, the upper extremity of the undefined side is checked and followed by the affected side. And the components, whatever that is, their functional components are real-world upper extremity functional components. And it takes roughly around 25 to 30 minutes. And then again, these are basically like qualitative measures, but the components, it's a quality of movement that is measured quantitatively. So it is a qualitative. ARAT is another one, action research arm test. We are evaluating the grasp and object manipulation capacity of the upper extremity. And these are the component subscales, the grasp, pinch, cross movements and everything. And again, this has 19 items. Again, it's a scale where you rate from 0 to 3. And the total score is, highest score is 57. As I already told you, this also quantifies basically the upper extremity impairments. This one, unlike the WMFT, may not, when compared to that of the WMF, totally it takes about 25 to 30, and those are the contents that which are evaluated. Again, they are real world object handlings, like means they are whatever the contents are there, they are like they are real world objects. Box and blocks, this is a very common one that is used. It's a very easy one. Standardized box and box test is available. Just need to go through the website and tell what should be the size of the cubes, what should be the box size and everything. You can prepare it accordingly. And the scoring is basically how many box, how many blocks you can move from the container to the other one, and the numbers, that is what is taken in account for a specific period of time, maybe 50 or 100 seconds like that. And each hand is separately scored. The highest score means better manual dexterity. We move to the next one. The next one is the 9-hole tech test. You can see that 9 holes are available, and you're supposed to move the pegs from the container section and fix it to the peg hole. And basically, again, number of pegs that which are fixed onto this one at a specific time, that is what is evaluated. This is yet another one, may not be that popular, but still used in many of the research works and all. Xerox test basically is like, emphasizing on bimanual tasks. So that is a core area that is addresses. It is not unique side, or it's not evaluating one extremity alone. All these 5, it was more of one extremity. Now this one focuses on bilateral activities, and it assesses basically 13 functions. the 7-point scale, and higher the rating, better the mind manual capacity of the person. And this one is the bedside upper limb functional evaluation tool. As I already told you, this was developed like a few years back, and now it is in a public platform for usage. It's a 12 test item. As the name implies, you don't need any equipment. It's a very simple designed equipment. It is done in the bedside level itself. And the total score, the highest score is 48. And the higher the score, the better is the performance. It is basically by observation you score them. There is a scoring chart. I mean, you just need to follow as per the scoring chart. Maybe like there are few limitations, considering that's a very limited time. It hardly takes 10 minutes for evaluation. That is the beauty of it. There is no resource required. Technically speaking, it is resource nil kind of test. That means you don't need anything. Bare hand is required with a paper and pen, and you yourself evaluate the patient. The focus is basically on gestures and certain grip and grasp activity, where the examiner's hand will be held or the finger will be held for evaluating the strength of the upper extremity or the hand component. And these are the 12 components, asking the patient to salute, holding the nose the way that has been depicted there, hand waving basically at the rotation of the shoulder level, similarly like clockwise and anti-clockwise rotation of the wrist, showing a point index and with wrist in extension, gripping the fingers of the examiner, similarly opposing the main and the thumb as well as the little finger, and the examiner trying to break that, asking the patient to hold with the index and the thumb, the examiner's finger, snapping the finger, snapping action, similarly asking the patient to gesture number 3, and then scissoring action. And the last one, finger tapping, the first 4 fingers excluding the thumb. Now, there are many other advanced technological devices also available. For example, robot-based assessments are available for evaluating the forces, the strength, and everything like that, as the pictorial representation shows. Basically, they use sensors and actuators for tracking the movement and then rating the movement. And they are standardized processings. Examiner might have to guide the patient to, or the robot itself might give the instruction to move in a particular way, and then the ratings are done. Now, what are the benefits? It's basically analyzing aerodynamic variables, the force, how much time it is executed, the smoothness of the movement, accuracy of the movement, as I already told you, also reduce those. So many things that you can see here in the pictorial one, you can see asking the subject to draw eye, then a diamond shape is one, a circle with the hand, and then rating them. The subject is able to draw eye, well, no errors. It has a good reliability. The reliability is as good as 0.81. The combination of the reaching activity, hand rotation, grasping ability, and all those things have been found to have a higher correlation to the clinical assessment scores. And these are the additional ones, and there's a long list of robotic assisted evaluation tools like big manners is there, acting norms are there, similar things are available. At the same time, when you look at the correlation component, overall, when you look at the clinical assessment tools like FMA or other components like that, you can see that the correlation values are either medium or strong. So it is all around the 40-50 towards strong correlation around, and few of them are having a score of around R value of 0.83 like that. So medium to strong level of relationships are there existing between these quantitative tools and the qualitative bedside or evaluation tools that we use, in clinical practice. Now, what are the predictors? Again, if you look at since many years, a lot of studies have come on predictors, like, for example, like the ability to move the little finger, the ability to raise the index finger, the ability to bend the elbow. Similarly, like all those things have come with respect to the motor functions. And of which the SAFE criteria is one of the common ones that is used nowadays. The subject can affect the shoulder, if he can extend the finger, that to the middle ones, within 5 days, then there's a high possibility that the patient will be able to recover his dexterity within 6 months of time. So, as I already told you, the probability is highest if that can move better within 72 hours. And these also help in deciding what to be done for the patient, how intense the rehabilitation should be, and you can prioritize an objective, the objectives or whatever means what you have to do for these particular patients can be done based on these criteria. Basically, the active range of motion, that is what is evaluated, not the passive one. And again, within a 1 month or within 1 week or 1 month may help in predicting what will be the status after 3 months or 6 months. And that's it about the predictive component. Further, there are many other aspects. If you go like, even muscle strength has been considered to be one of the predictors. Similarly, like, sensory component, movement discrimination has been a predictor. Site of involvement, right hemisphere if it is involved, not dominant hemisphere is involved, there can be more issues, especially if there's a neglect there. Similarly, even cognitive impairment also has been, associated with it. Speech has been associated because speech areas where the hand functions are close to each other. Naturally, if there's a speech involvement, again, that is also considered to be one of the strong predictors. Like if there's involvement of the neglect or whatever it is, naturally, you have to think about management of perceptual issues, and that should be the focus, which may include encouraging the patient to do better visual scanning, each of environment and everything, or environmental modifications like that to take care of these troubles. So that's all about the assessment component. As I already told you, 2 sections are there. So if you have any queries regarding the assessment function, you may ask right now. I think I have lost rushing. That's a good question. First of all, let me tell you, my apologies. I'm basically into adult neurodevelopment patients. My area of interest is only that. I don't know whether you have seen the textbook also. My book is on adult neurodevelopment. So if you're asking me, it is a little tricky question, and I'm not interested in giving any wrong information. Very clear. If I don't know, I'll say I don't know. That's it. Got the point, right? So if you have anything with regard to adult component, yes, you may ask. Pain. That's a very interesting question. We neurophysical therapists, let me tell you, we don't give much weightage for the pain. It's basically like you have to realize that subject has paralysis, subject has pain also. Got the point? If the pain is excruciating and if there is associated, like say for example, if there is complex sympathetic dystrophies or something like that, or RSDs like that, then you have to address that. If there is severe edema, swelling, there's something called minor catharsia, major catharsia, and other things like that. In that kind of situation, maybe that has to be addressed. But otherwise, if it is just only pain with no physical evidence of no swelling, nothing is there, you have to encourage the patient to move the limb so that they will be out of that particular issue. Otherwise, the emphasis will go in that direction. So yes, if it is a major concern, then you address that. Maybe in that situation, you might give TENS therapy or IFP, or if there is swelling, you might give the acute case, you might give cold packs or something like that. The cold case, then you might give hot pack, keep a track on everything. And if there are some tender points, you might give some ultrasound too. But otherwise, the emphasis is less for pain management. I always cite these 2 examples. I think Ashish should have heard that. Like basically, imagine a situation where, but don't tell this directly to the patients, it's only for your understanding. Imagine you don't have an option. You have to choose between a robber and a serial killer. You have to stay with the person whom you will choose. Correct, right? Rover, very good. The maximum at rover. Pain and paralysis is like that. You got the point, right? So from a neuro-rehabilitation point of view, if you look at the management part, you take any textbook, whether it is about muscular dystrophy or whether it is stroke or whatever it is, pain is not kept in the higher order. I'm not telling you pain is neglected. Please don't take it that way. The emphasis is given for other components. But if the pain is coming in the way, definitely you have to address it. For instance, the subject is having subluxation of the shoulder. And that is really detrimental. And it is in fact involving or it is affecting the movement. Then you have to address that. But say like it is not very obvious or it is rather like not on the higher level, but simply the patient is dragging with this pain aspect, then better like address the other aspects of it. You got the point? You have to reassure them. You have to tell that basically like see, your muscle weakness is the cause behind the impingement. If you can improve that particular thing, the pain will disappear. You got the point, right? So that is why the schools of thought is slightly different when it comes to pain management, especially with regard to neuro rehab. Whereas if it is orthopedic, it is other way around because the pain is the usual limiting factor for the muscle activity. There you have to address the pain. You got the point, no? The priorities differ. Anything else?
On initial assessment, how will you get to know whether the hand function is lost due to MS, musculoskeletal or neurological damage? On initial assessment.
Best way to know whether it is musculoskeletal or neurological. That is again double discipline areas, but you're asking me hysterical, I would answer that one, but then now it is between pain of musculoskeletal origin or pain of neurological origin. Right? So basically, two methods, evaluate them. Historical one, you take it, whether it is like falling for radical low or any of those kind of components you have to see, the presentations you have to see. And then after say like it is not that, but due to some muscle related or joint related one, then address accordingly. In addition to that, radiological things also will be supportive about that. So you have to take a call. So in that case, you have to holistically handle that, not from one system alone. That comes the importance of actually shifting two systems. For instance, sometimes when certain patients come with pain, well, I am sure that like it was not falling in the neurological one, I don't handle that. I immediately hand it over to Ashish or more that is there as a musculoskeletal. That is what we do. We don't handle the system by ourselves. But what we do is that we'll do a screening. By checking the history itself, we'll come to know fairly well whether the percentages are going in line with or inclining towards a musculoskeletal. Or if it is more of neuropathic in nature. The behaviors do differ. A radicular pain is different. In addition to that, there can be negative fighting source. Say, for example, typically in case of severe radicular involvements and all complexopathies and all those things, there can be muscle wastings and all which are not characteristic in a musculoskeletal condition. Understand it is a real prolonged. Got the point also, we have to take into account with it. So as I already told you, when your area of interest is very specific one, what we do in our center, we tackle that way if it is in our doctor. We don't try to treat the patient with an assumption. You got the point, right? That is why specialties are there. That's how we grow. And in case if you think that yes, it is not within the domain, immediately the patient has to be transferred to the next unit so that they can take a call. If still there's an uncertainty there, definitely we'll interact each other and then we'll amicably try to handle that patient. Especially in case of psychosomatic issues and all. Got the point, right? For hysterical and all is easy. Got the point, for example, hysterical outreach check. Say the patient might say that like he's not able to lift this leg. What he will do? Let this leg be there only. Ask the patient to lift the other leg and give a resistance to the other leg. You will see that these muscles are getting tensed up. Which should not happen if it was paralyzed. What the point is, the spherical one we can do in a different way. But when it comes to musculoskeletal related one or neurological one, go thoroughly through the study. That will give some information. Based on that, you do the observatory findings and the test. And if you think that it is in line with musculoskeletal, go in direction. If you're very sure that it is neurological, then handle that. I think that answers your point. No problems. Okay, so shall we proceed to the next one? Yes, sir. So that now that we know what are the important assessment tools, we'll just serve through. This is the only word I can use. We'll serve through what are the important rehabilitation strategies that are used. So to begin with, these are the three components. I hope this is clear for all of you guys. And different categorizations are there available about the therapeutic strategies or the treatment strategies. Only one we are depicting here. For example, what are the strategies that which focuses on ipsilateral brain cortex? What are the things that which focuses on contralateral brain cortex? What are the things that which works on the limb or directly applied over the hemiparetic limb or utilizing the hemiparetic limb? And what are the things which helps in transferring from the unaffected side towards the affected side? The list is long, and some of the components have dual or triple level presentation. Say, for example, if you look at it CIMD, if you look at it, it activates the ipsilateral cortex. It helps in minimizing the learned non-use and encourages the use of the paretic side. It also directly works on the extremity too. So multiple levels are there. This is what I'm talking about. Now, in addition to this, let me tell you also there are other categorizations also. Say, for example, like I don't know whether you have heard, there is something called as top-down approach and bottoms-up approach. Top-down, as the name implies, you work on the cortex to activate the paralyzed side. For instance, have you heard about repetitive transcranial magnetic stimulation or RTMS? That's a part of it. CAB itself is also top-down approach. Roots approach, roots approach, you give facilitation techniques and inhibitory techniques peripherally at the muscle level or at the sensory level of the extremity. That's a bottom-up approach. That means you are giving the necessary inputs basically to control the cortex or rather to enable the better movement. The other one, it started, the initialization happened from the cerebral cortex to activate in the right pathway. You understood, right? So that's top-down as well as bottoms-up approach. Many of the early components of root strokes and all those things are also bottoms-up approach. Got it right? Whereas in case of task-oriented approaches, MRP and other things like that, motor rehabilitation program, which is basically top-down approach. Got it right? I'm not telling that all the components within an approach may be this way. Some of them are pro for it, some of them are more of top-down and less of bottoms-up like that. Now coming to the conventional therapies, this one, as you know, it's one of the oldest schools of thought. And basically, you can see that in the early phase and all those things they promote. So again, the focus is only on upper extremity and hand function. So I'm only going to talk about that. The early phase and all those things, the approach promotes mass grasp as well as mass release. Similarly, it also promotes bimanual activities and all. And then you can see it also like different kind of techniques are used. For example, proximal traction response is used. Proximal stabilization of the extremities and all those things are used. Extrusive stimulation, proprioceptive stimulations and all those things are used. Something like roots approach. You heard about that quick stretch and all, right? Quick stretch. Similarly, like quick IC. You understood? Oh, yeah, exactly. All those kind of similar kind of things are used here. This is taken from the same book that was published earlier. So if you can go through that, soft copies are available. I mean, library has one at least. So you can use those things. If not, the parent article is there, that is movement therapy in hemiplegia, the original footstrokes. textbook. You can go through that. Almost all the components are there in that particular book. Now, here you can see what are the ways of relieving or reducing or inhibiting overactivity of certain muscles. Because overactivity can be due to mainly due to spasticity. What are the methods? You can, what you see, the top one is Snook's phenomenon. That is a passively, if you elevate the arm like this, the relaxation in the flexor muscles, and to some extent the extensor muscles, the long extensors may get augmented. So there are other methods also. There's something called as manipulation of the thumb and the rest of the fingers. A set of exercises mentioned by Brimstone to enable or to activate the extensors and inhibit the flexors. So that way, that will help in better release and also helps in better manipulation of the object. So when you talk about release, let me tell you one additional point. Whenever you want to handle an object, whenever you want to take an object, earlier I told you what does it want? Reaching towards the object, orienting towards it, and then grabbing, right? See that was the thing that was told earlier. So whenever you are reaching the object, the hand should not be clumsy or it should not be like this. The hand comes like this, absolute failure is. So the most important thing that is required is a free hand. You know that basically at flexed attitude is not advisable. The subject should be able to bring his hand with his fingers in extension. Then only they will be able to maneuver or rather orient themselves and hold on. You got the point, right? So there comes the importance of release. That means it's not just grabbing. Let me tell you one more thing also. Many times, physical therapists as well as the doctors, bystanders, and also even the information on the online platforms, they say that if the patient has weakness of upper extremity, give sponge balls, smiley balls. You understood, right? Let me tell you, that is one thing which you have to be carefully executing. The reason is that if you give those kind of things, the person might keep squeezing only the ball, and as a result, what will happen is that may increase the strength of the flexors, and in the bargain, there may be no scope of release happening. Because as I already told you, without release, you cannot grab. Because the release is the first thing that is required for an effective grabbing. You got the point? Then only you can orient yourself. Then only you can maneuver the object. With a fixed hand like this, turned up like that, forget it, that hand is not useful for handling any object. So yes, like uncontrolled use of these kind of tiny balls and other things and other things like that is a many times physical therapists without the knowledge they give it, or sometimes the neurologist, the physician might encourage based on some reports and some other, the videos and other things like that. They have to be taken very cautiously, discourage the patient and ensure that there is a balance between encouraging the extensors and the flexors. So that is what you have to keep in mind. Going back to now this one again, I'm not going much into it. The emphasis is basically on minimizing the abnormal tone, abnormal posturing, encouraging normal movements, normal experience, normal sensation of movement, and also encouraging better alignment of the body segments, better control of the posture. These are the main principles of NDT, or in other words, Mudra Sankoch. And the training components you can see here focuses on minimizing spasticity. You might use reflexivity patterns of movement, prolonged stretching and other components, encouraging normal movements and all those things. Task-specific trainings are given. Alignment again is here. It's very important. Now, with regard to you can see last in the line, when it comes to evidence, the evidence is inconclusive and it can be considered as a low-level one. I believe what you know by evidence, right? Isn't it? Evidence means based on the research work. Many people do NDT as an important part of treatment or strategy, but try to understand that till date, the inclusive evidence, and whatever that is there, overall it is considered to be low in level. There are many reasons also why I'm not going into the nitty-gritties of the matter. MRP developed by Carr and Shepard, Jared Carr and Robert Shepard developed these things. They were actually the disciples of Bobath, and later they developed their own schools of thought. Here we can see that the important components are these four. Basically, analyze the task, practice whatever that's missing, and practice the task itself, and then try to transfer the task into the more daily or different type of activities. What are the things that it is aligning to that? Basically, it activates the participation of the patient. It is practice with feedback, transfer to the real world situations. These are the things. Now coming to a few examples. For example, if you use MRP for improving the hand function. For instance, like if the subject wants to be promoted to take grab a cup of glass or water or something like that, or an empty cup, this should be the method. Reach, open the hand, which I already told you, grasp it, and practice it several times. And then after that, next is practice with water in it and transfer it, like rather just doing it on glass itself, try to use other items. So for example, maybe a brush, maybe a comb, whatever that is used for routine activity, maybe a pencil or a pen or whatever that is we use, like to utilize, those things have to be done. There's a need also for scaling. Like scaling means different type of weight item. The size might look same, but the weight might differ. That is also have to be done so that the person will be able to do it. Coming to the contemporary therapy approaches, CIMT, again, very popular one by Edward Thorpe. The selection criteria for CIMT is minimal 10 to 20 degrees of wrist extension. Thumb should be able to move a little, 10 degrees actively, not passively. And there should be certain amount of movements of the digit also towards extension. At least 2 fingers, that is what's important. And of course, the subject should have only minimal or minimal cognitive deficit or minimal sensory deficit. That means the subject is not able to move at all the joints. If he is having severe spasticity, if he is having severe cognitive deficit, severe sensory loss and all, they cannot be included for CIMT. Now, a little bit about this forced use. Let me tell you, the original concept is taken from forced use. Way back in 1997, Ivory Shepherd and Roberta Och, these were the 2 people that is actually laid or rather gave the foundation for CIMT or rather gave the idea for CIMT. Only by 1950s or 60s, Edward Thorpe realized the importance of it, and we utilized and capitalized the research output which was given in late 1800s. So you can imagine that the CIMT, though this practice right now, the roots of it, the original concepts, they were laid back way behind almost 100 years before from now. So that old it is, of course, yet tweaked it. The concepts are changed a lot, but the sources, the original sources remain same. Those times it was called as forced use therapy or forced use rehabilitation. Intense practice, that is what is required. It is found to be effective for learning purpose. There will be improvement in cortical reorganization. It minimizes learned non-use of the unaffected side, encourages activity of the affected side. And there is a moderate amount of evidence supporting both traditional or conventional CIMT and the modified CIMT for improving the quality of movement functionally and all those things for those selected patients. Mental imagery, as the name implies, you ask the patient to imagine the movement with no overt or actual movements. That also is supposed to promote neural plasticity. There are 2 aspects in that: kinetic imagery and visual imagery. Kinetic is the subject is performing an imaginary movement. He performs. Subject is the act. Subject is the act of performing the imaginary movement. The other one is he himself is spectator for the mental representation of the body. So these are the 2 aspects of it, and that's it. And again, this is also found to have a moderate amount of evidence, but it's not a standalone treatment. It has to be done as an adjunct along with the rest of the therapies. For example, if you take a hand function, say for example, if the patient is struggling to open a jar, As a therapist, you can encourage the patient for a mental imaginary exercise in the form of asking the patient to imagine, like by saying that close your eyes, imagine holding the jar in your hand, feel the texture of the lid, visualize your fingers are around the lid firmly, like that. Ask the patient, imagine that he's thinking to roll or turn the lid counterclockwise to open out to loosen the lid of the jar. Like that, ask the patient to feel it, that or basically imagine it. And then after that, most these things, the patient is asked to perform active movements using the same tactics. They may do better. So that is what has been found. So here, the initial part is there's no overt movement, but there is an active engagement of the patient. And that will help in activating specific regions of the brain, particularly the premotor cortex and other regions and all those things, which will help to plan the movement better and also to execute the movement more efficiently. So that this also is enhancing plasticity. The supplement, as I told you, is an adjunct. Mirror therapy, of course, it was not used generally. I mean, it was in the beginning, it was not used for stroke. It was used for certain other conditions and not within the nitty-gritties. For many other conditions. Later, it was extrapolated for stroke rehabilitation and other things like that. And again, it basically enhances neuroplasticity by activating the premotor cortex by using the visual feedbacks. Basically, it is nothing but tricking the brain by the mirror, and the patient thinks that is basically moving the affected limb. The affected limb is hidden behind the mirror. All that is seen is only the unaffected side that is moving, with a reflection of the same on the other side. Naturally, you think that the reflection is the paralytic limb. So that is what you can see. When the picture is there, miss that picture there. That is about mirror therapy. Examples are there. FPS is another important thing. Both FPS as well as FPS, the name is the functional electrical stimulation, as well as neuromuscular electrical stimulation. The funda is simple. Basically, they activate the muscle. The current activates the muscle, and that in turn, if it is incorporated to the functional activity, that will augment the movements. It will improve the strength of the muscle. To a certain extent, it will activate or will encourage better movement outputs. To a certain extent, it is a bottoms-up approach because it stimulates the distal structures, it gives sensory feedbacks, and that in turn will help for better neuroplasticity from the periphery. You can see that basically it reduces spasticity and all. Clinical benefits, as I already told you, FPS is supposed to improve the strength, range of motion, enhances the functions like grasping and reaching. And again, here also, basically, FPS is used as an adjunct. The mainstay is basically the routine exercises, the ground exercises, and whatever that is followed. Stand not continuing it. Some pictorial representation issues are there. It has not been depicted here. The pictures are missing. Virtual reality. There are a lot of pictures there. No, it's not there. Not there. Here it is there. Okay, so virtual reality, as you know, is nothing but simulation. The patient is a simulation system. It might be in immersive mode, non-immersive, or partially immersive, or something like that. The advantage is that it's more entertaining, and the interest for the patient to do it for a longer time is there. The subject can repeat many times. So high intensity activities, repeated activities are possible. So that way, that also will help for a enhanced neuroplasticity. In addition to that, these enriched environments, virtual reality, immersive kind of things, they will definitely help for a better neuroplasticity. That is what you have to keep in mind. Moderate evidence is there when you use this as an adjunct. Robot assisted therapy is now, this is a world where now everything is technology driven. So we can use these things along with effector devices and exoskeletons and all those things. Here also the advantage is that with the device on, the patient will be able to do intense practice with lot of repetitions. So that is the beauty of it. Of course, when it comes to these kind of things, you need the right centers, you need the right and basically it is not cost effective and they cannot be available for the common people. So you need the right centers there. But studies, whatever that is they're still done, they have shown promising evidences provided they are used as an adjunct. Brain-computer interface is also a similar thing. It is again a new technology-based one where EEG electrodes or subdermal electrodes are fixed onto the scalp that will pick up the activity of the brain, and then using algorithms, these particular brain activity will be sensed and the role of that particular, from where it is emerging, that will give an idea of what the person is intending to do. And then based on that, the impulses are given to the parietal clip for the movement, and that also is supposed to help enhance motor learning. So basically, again, for grabbing activity, for grasping or grabbing activity, gripping, for opening, for releasing and other things, objects and all those things. Again, it is good. I'm so sorry that there are a lot of pictures on the side. Somehow all those things are missing here. Repetitive movement. Again, now repetitive task movements, it is not an approach per se. Many of the approaches, whether it is Lundstrom, Popart, the task-oriented approach like MRP, whether it is things like virtual reality, robotics, they all use this repetitive task. The important thing that we keep in mind is that we want to have an effective motor learning, all intense repetitions are required. So if you practice it more, things will become more and more stable and permanent. That's all about the repetitive task. So high dose means many therapies, many repetitions, and many sessions. You have to continue like that to get an enhanced plasticity. That's all about it. And there is an example also, like when it comes to a very short example. That's about the repetitive task and all. Now, I don't know whether you know this particular approach, the action observation therapy. Have you heard about something called mirror neurons? Okay, mirror neurons, when you observe certain people, and then when you're observing them keenly, what they're doing, our neuronal cells in certain areas also will get activated. And that in turn will help kind of kickstart, or it will help to enable us also to replicate those neurons. The mirror neurons are there within our brain, particularly the inferior parietal lobe area, prefrontal cortex regions, inferior frontal gyrus area. These are some of the areas where mirror neurons are there. Monkeys tend to replicate things. You know that? Yes. So basically, that is what. So the same. So now don't think that only monkeys replicate. We also. At the very young age or all those things, we do observe others, right? And then try to imitate. Oh, this is nothing but imitation. So observation, action observation therapy is basically observing a movement what others are doing, so that will help to activate our mirror neurons, which will help in starting the similar kind of responses in us. So that is what is about action observation therapy. This is also been published from 2015 around. A lot of works are there in this line also. Again, it is found to be very good in improving the dexterity, muscle strength, and all those things. But evidence are mixed in nature. Like that means there are some that is supporting it, some of them are not very much proving that. So that's all about it. So here, if you look at it in general, there is a moderate quality of evidence for CIMT, mental practice, mirror therapy, and there are also interventions where sensory impairments are being handled. Virtual realities are there. Just now I told about the importance of repetition. High repetitions are also promising. Similarly, when you're comparing between bimanual task and unilateral arm training, unilateral arm training has given more emphasis. So these are the existing evidences with regard to upper extremities, specifically hand training. The same can be extrapolated also for lower extremity, gait, and other things like that. But since the focus is more on upper extremity, I have only picked up the contents that which are more in line with that of upper extremity. That's it. And the references are there here and there. I have given in the last section of the slide too. So I hope that I did some justice by elaborating here and there at least some of the components with regard to the hand management part. So that's it. Thank you. Specifically, the words are playing, but not the ears. By the way, if you have any queries, yeah, any questions from the audience? Thank you again also for one or two things from your question. I now like doctors to participate the jokes also. Thank you so much.
ठीक है तो फिर स्लाइड ओपन करो तो हाँ ठीक है Thank you.
So, our next speaker is Dr. Ashish Pataga, sir. He is an associate professor, Department of Physiotherapy, faculty member, Innovation Hub, member research cell, KMC Bangalore, Medical Academy of Higher Education. Our talking points are various achievements like achieving 400 for best research publication for the year 2025 at KMC Bangalore, Mahe. Second cluster of paper presentation at Quadmux 2020, organized by 8 Institute of Physiotherapy, Belgaum, Karnataka. Also, this presentation at RPG Com 2024, organized by RP College of Physiotherapy and the RPG Bangalore, Karnataka. So has invented one title as well as he has many corporate terms. I welcome you, sir, on this school of physiotherapy sometime. Very good afternoon. Two points. It's very difficult to give a talk. Please see me for now. One is after lunch, one is when we are packing up. If you are away, it's difficult to talk. Right? You want me to be more louder? That's okay. Okay. So I was trying to concern regarding your exposure in the hospital because as I was talking on ACL. So he said that you have ample of cases about ACL. Am I correct with this? How many of you have seen ACL patients? Okay, there are good amount. How many of you have seen ACL after surgery? Very good. Super. So the ACL stands for anterior calcaneal ligament. Extending from olecranon to. Okay, those are laughing is they're picking up my blunders. Right, with this? Okay, I'll not go in detail with the anatomy. Obviously, I'm sure in a couple of months you'll be graduating, so you will be very, very good with anatomy. Right? You see some smiling faces. So that's a question mark. No, very good. Excellent. Okay. I will rush to that. I will not go too much in detail of that, but we'll focus a lot about what advances are there in the surgical aspects, which is necessary for you to understand because your entire rehab protocol is based on that. Here, there's a common understanding that we don't have to focus on what surgery has been done is because that is none of our concerns. No, your entire concerns is on what surgery has been done because your entire protocol is based on it. So you need not only understand the anatomy, you have to also understand the mechanics, you have to understand the tear, you have to understand the investigations, you have to understand the surgery, and then you have to plan your protocol. I'm not wrong with this. Right. Okay. Does ACL have a rehabilitation has a protocol for rehab? Is it a strict protocol? No, it's not. It's not like a kitchen recipe. What do I mean by kitchen recipe? Other much and not take so much of the no. All these protocols are just a guideline. You have to alter them based on your patient convenience, your patient's output. In terms, you might be treating a patient who is not sports person. You don't have to actually focus them on getting back on track. So your rehab is going to be just getting it functionally. So how long are you going to train the patient to get back to sports? A month, 2 months? 9 months minimum till he gets back. Why is that necessary? So that he doesn't have the re-tear. Am I correct with this? Yes? Okay. You said you have taken a lot of ACL cases. Have you taken the good history about the ACL injury? How many of you asked them, did they have pain after the injury? Do they have pain after the injury? Yeah? Many don't have pain after immediately after the injury. Correct? But why? Do they have swelling? How early do they have swelling? Does it matter? Immediately? First question, why they don't have pain? Because they don't have no neural receptors for pain. Am I correct or wrong? They have no neural receptors for pain, that means they do not perceive pain. Then why do they come with pain eventually? That is because of the swelling that is there, the hemarthrosis is there. I have the duration of swelling. Why the duration of swelling matter over here? Whenever you're taking the history, duration of swelling matters because if the swelling is immediate, it is not necessary fracture. You can rule out fracture on two aspects. Are the patient are they able to walk or not walk? If he says I was not able to walk, then you can say that there was a fracture. If he's able to walk, it's more of a soft tissue. So the swelling is because of some kind of hemarthrosis, accumulation of blood in the joint, secondary to maybe the cascade of events that starts after the injury. It can be minor blood flow. ACL has blood flow or no? What is the blood supply? The anatomy. There's no blood supply, no. Middle genicular artery. Correct. I skipped anatomy thinking that the anatomy is superb. But anyways, I'll not go back in detail about the anatomy. Anyways, still fair enough. Already told about this. This is just a brief about how long is your ACL. ACL is approximately 4 centimeters in length. Correct with this, it's hardly 1 centimeter in width. So that as big as your pencil or your finger. Now, why is it necessary for us to know the length and length? Because it is connected to the length and the length of the graph that needs to be fixed. So that is none of our concern, but this is an additional information which you should have. All right. The neural supply that there in the nerve is only based on mechanoreceptor. That is progressive. What is proprioception? Joint position sense. Can we give an example of that? I don't have to ask you in what position your knee is right now. You just know that it is fixed. That is your joint position sense. So here, when you rehabilitate the patient, the proprioceptive feedback of the training is very important. We just focus on what? Strengthen the core, strengthen the core. So not only strengthen the core, we focus a lot on proprioception so that they will not re-injure that in the future. That is why you need to understand the anatomy and the supplies that is there in the nerve, or the ACL for that matter. Okay. Now ACL again, what is it necessary for? Anterior translation and medial rotations. That is what it checks for. So that is why it is seen in high impact traumas. Or is it not seen in normal injuries? It is also seen in normal injuries. Only difference is that trauma is bigger. Right? So why do athletes have more injuries? Though they are so heavily trained, it's because of the muscle or the body can't overcome the force that is exerted. Can anybody tell me how much force can your ACL take? 2,700 newtons. How much is that? We convert it into kilograms. 9.8 newtons is equal to 1 kg. So approximately 250 kgs of tensile force your ACL can take. That is sufficient enough. Our body weight, if we are reaching 217 body weight, then we should not be alive. So that much amount of force your ACL can take, that much amount of force it can withstand. If still it tears, that means they are involved in high impact traumas or road traffic accidents or something that the muscle or the ligament couldn't overtake. Anyways, again, why is it necessary to know about the tensile strength of the ligament? Because the graph that is fixed has to be able to take that much amount of load. Clear with that? Okay. So this is about the blood supply, the biomechanics you already know. These are the Newton forces. Again, I told you to take that much amount of strength because when you are rehabilitating those individuals, you should know which activity is causing how much. When you are normally walking, how much amount of force that is exerted on the ACL is approximately 400 newtons. So that much amount of exertion is okay for the graph to take. Right? There are some literature stating that you should not be doing dynamic pulse after ACL. Nothing is going to happen to the patient because your graph is able to take more than 100 to 150 kgs of weight. Your lower leg weight is going to be how much? 4-5 kgs. It can easily take. There is no problem going to happen to the graph. Provided the surgical aspect is absolutely perfect. Anyways, these are small videos. Can you just play with that? Other one, the right one. In mute sound. First one doesn't do it. Second one isn't good. If it's not playing, it's okay, no problem. Was regarding the mechanism of the Hope the other videos do. Anyways, so this is about the classification for your ACL. ACL is divided, the tear is classified into 5 types based on where it is involved. The first one is at the attachment level. Second one is 75% below. Then the third one 50%, and so on and so forth. There is an avulsion injury, it is grade 5. These are basic grades of strain. I'm not going in detail with this because you are already aware about this. We go with the symptoms. Some of the patients do complain of giving away. There is swelling, reduced range of motion of the joint, and some do complain of pain because of hemarthrotic accumulation. Okay. When we come to the physical examination, what are special tests should we do for ACL tear? Very good. Then attachment test. Then pivot shift test. Then anything else? Compression, please compression. That is for meniscal injury. That is obvious compression of macro. For ACL, we restrict to anterior downward. Best one is the laterals. Then there is a pivot shift test. Then there is an LI test. One of the most, my favorite one is the LI test. Anyways, okay, where are the videos? Oh, none of them are playing with something. Technical issues. Okay, fine.